The signal you've been ignoring every single morning. He had been waking up this way for 11 years. Robert Callahan, a 68-year-old retired high school principal from Columbus, Ohio, had a morning ritual so consistent it had become invisible to him. Every day, without exception, his eyes would open before his alarm, and the first sensation, before awareness, before thought, before anything else, was the inside of his mouth feeling like the surface of old sandpaper. His tongue would stick to the roof of his mouth. His lips would be cracked at the corners. He would reach for the glass of water on his nightstand before his feet even touched the floor. He had been doing this for so long that he no longer even registered it as a symptom. It was simply part of waking up, part of being 68, part of life. His wife noticed it before he did, or rather, she noticed that he never mentioned it, even though she had watched him lunge for that bedside glass every single morning for over a decade. One evening, while they were watching television, she turned to him and asked, "Have you ever told Dr. Mercer about the dry mouth thing?" Robert looked at her blankly. "What dry mouth thing?" She stared at him for a long moment. "The thing where you wake up every morning and immediately drink an entire glass of water because your mouth is so dry you can barely open it?" He genuinely didn't know what to say. He hadn't realized she had noticed. More importantly, he hadn't realized he had been treating it as normal when it was anything but. At his next appointment, he mentioned it to his doctor almost as an afterthought, something to fill the last 2 minutes before leaving. Dr. Mercer's pen stopped moving. She looked up from her notes and asked him 3 specific questions. Based on his answers, she ordered a panel of tests that Robert hadn't expected. And what those tests revealed changed not just his understanding of his dry mouth, but his understanding of his health in ways he is still processing today. If you wake up with a dry mouth, if that sandpaper sensation, that sticky tongue, those cracked lips are part of how your mornings begin, this article is for you. Because what your body is telling you is not nothing. And in many cases, it is not simply drink more water before bed. It is a signal. And signals, once understood, can save your life. What dry mouth actually is and what it isn't. Let's establish something clearly before we go any further. Occasional dry mouth is normal. If you spent the previous day in intense heat, drank alcohol the night before, or slept with your mouth open because of a stuffed nose, waking up with mild dryness is simply the body reporting what happened. That is not what we are talking about. We are talking about persistent morning dry mouth, the kind that is there most mornings, regardless of what you drank the night before, regardless of the weather, regardless of whether you slept with your mouth open or closed. The kind that has been part of your mornings for months or years. The kind you have stopped noticing because it has become the background noise of waking up. The medical term for this condition is xerostomia, from the Greek words for dry and mouth. It refers specifically to the subjective sensation of oral dryness, typically caused by reduced or absent saliva production. And while that definition sounds clinical and contained, the implications of reduced saliva production extend far beyond the inside of your mouth. Saliva is not simply water that your mouth produces to help you chew and swallow. It is, in fact, one of the most biochemically complex fluids in the human body. Saliva contains enzymes that begin the digestive process before food ever reaches your stomach. It contains antimicrobial proteins that protect your teeth and gums from bacteria. It contains bicarbonate, which neutralizes the acids that cause tooth decay. It contains growth factors that help the tissues of your mouth heal and regenerate. And it contains something called mucins, large glycoprotein molecules that coat and protect the delicate lining of your mouth and throat. When saliva production drops, for any reason, all of these protective functions are compromised simultaneously. This is why chronic dry mouth is associated not just with discomfort, but with significantly elevated rates of tooth decay, gum disease, oral infections, difficulty swallowing, impaired digestion, and altered taste perception. These are not minor quality of life issues. For adults over 50, they can cascade into serious health consequences. But here is the part that most people, and frankly, many primary care physicians, don't fully appreciate. Persistent morning dry mouth is, in the majority of cases, not a problem with the mouth at all. The mouth is where the symptom appears. The cause is almost always somewhere else in the body, and finding that cause is what changes everything. The 5 things your body might be telling you. When Dr. Mercer paused and put down her pen, she was running through exactly this list. Because experienced clinicians know that a patient reporting consistent morning dry mouth is, in effect, handing them a diagnostic clue. One that points toward 5 distinct systemic causes, each with different implications and each requiring a different response. The first thing your body might be telling you, your blood sugar is dysregulated. This is the one that stopped Robert's doctor in her tracks. Persistent dry mouth, particularly the kind that is worse in the morning and accompanied by increased thirst throughout the day, is one of the earliest and most consistent symptoms of type 2 diabetes and prediabetes. Here is the mechanism. When blood glucose levels are elevated, the kidneys go into overdrive trying to filter the excess sugar from the blood. To do this, they draw water from surrounding tissues, including the salivary glands. The result is reduced saliva production and a pervasive sense of oral dryness. The body is essentially dehydrating itself from the inside in its attempt to manage blood sugar. In the United States, approximately 38 million people have type 2 diabetes, and a staggering 96 million, nearly 1 in 3 American adults, have prediabetes. Of those 96 million, an estimated 80% don't know it. They are walking around with dysregulated blood sugar, and in many cases, the only symptom quietly announcing itself every morning is dry mouth. For Robert, this was the finding. His fasting blood glucose was 118, firmly in the prediabetic range. His HbA1c, which measures average blood sugar over 3 months, was 6.1%. Neither number was catastrophic, but both were signals his body had been sending him for over a decade, writing its message in the only language available to it, the inside of his mouth, every morning for 11 years. The good news, and it is genuinely good news, is that prediabetes is reversible. Unlike type 2 diabetes, which requires lifelong management, prediabetes can be fully reversed through dietary changes, increased physical activity, and modest weight loss. The National Diabetes Prevention Program, widely available through hospitals and community health centers across the United States, has shown that structured lifestyle intervention reduces the progression from prediabetes to type 2 diabetes by 58%. For adults over 60, the reduction is even more dramatic, closer to 71%. Robert's dry mouth was not a minor annoyance. It was 11 years of his body trying to tell him his blood sugar needed attention. When he finally listened, he caught it early enough to turn it around. The second thing your body might be telling you, your medications are causing more harm than you realize. This is the most common cause of dry mouth in adults over 60, and it is almost never discussed with adequate seriousness. More than 400 commonly prescribed medications list dry mouth as a side effect. More than 400. And the medications most likely to cause it are the ones most frequently prescribed to older adults. Antihistamines, antidepressants, blood pressure medications, particularly diuretics, ACE inhibitors, and calcium channel blockers, anti-anxiety medications, antipsychotics, medications for overactive bladder, certain pain medications, statins in some individuals. The mechanism varies by drug class, but the most common pathway involves the nervous system signals that control salivary gland function. Many of these medications block the neurotransmitter acetylcholine, which is responsible for stimulating saliva production, as an unintended side effect of their primary mechanism. The result is reduced saliva output, and the symptom is dry mouth. For many adults over 60 who take multiple medications, a situation called polypharmacy, defined as taking 5 or more medications simultaneously, the cumulative effect on saliva production can be severe. Each individual medication may reduce salivary flow by a modest amount. 3 or 4 of them together can reduce it dramatically. The critical point here is not that you should stop taking your medications. Most of these medications are managing conditions that genuinely require management, and stopping them without physician guidance can be dangerous. The point is that dry mouth caused by medication is treatable through dose adjustments, medication substitutions, timing changes, or supplementary interventions, but only if your doctor knows that you are experiencing it. Most patients never mention it. Most doctors never ask. The third thing your body might be telling you, you are chronically dehydrated, more significantly than you think. As discussed in the previous article about nutrition after 70, the body's thirst mechanism weakens progressively after age 60. Most older adults are operating in a state of mild chronic dehydration without feeling particularly thirsty. Morning dry mouth is often the body's most prominent attempt to communicate what a weakened thirst signal can no longer adequately convey. But here is what most people don't fully appreciate. The effects of even mild chronic dehydration on the body over time are significant. The kidneys concentrate urine and work harder to filter toxins. Constipation becomes more frequent and more severe. Cognitive function, attention, memory, processing speed measurably declines. Blood pressure becomes harder to regulate. Joint discomfort increases because cartilage is approximately 80% water and requires consistent hydration to maintain its cushioning function. Morning dry mouth caused by dehydration is, in one sense, the simplest of the 5 causes to address. But addressing it requires restructuring your relationship with water, not just drinking more, but drinking differently at different times, and understanding which other foods and habits are quietly draining your hydration throughout the day. We will return to this in part 3. The fourth thing your body might be telling you: your breathing pattern during sleep is disrupted. Sleep apnea, a condition in which the airway partially or fully collapses repeatedly during sleep, causing brief interruptions in breathing, is estimated to affect more than 39 million Americans. It is dramatically underdiagnosed, particularly in older adults and in women, for whom the symptoms present differently than the stereotypical loud snoring overweight man that most people associate with the condition. One of the most consistent daytime symptoms of sleep apnea is waking up with a dry mouth. When the airway is obstructed, the body instinctively shifts to mouth breathing, and mouth breathing overnight is one of the most efficient ways to dehydrate oral tissues. If your dry mouth is accompanied by morning headaches, daytime fatigue that sleep doesn't resolve, difficulty concentrating, or your partner has commented on your snoring or restless sleep, the cause may be structural rather than metabolic. Sleep apnea, left untreated, significantly elevates the risk of cardiovascular disease, stroke, high blood pressure, type 2 diabetes, and cognitive decline. The connection between untreated sleep apnea and dementia risk in older adults is an area of active and alarming research. This is not a benign nuisance. If you have any reason to suspect sleep apnea, a sleep study, now available as a straightforward at-home test, can provide a definitive answer. The fifth thing your body might be telling you: an autoimmune process is affecting your glands. Sjogren's syndrome is an autoimmune disease in which the body's immune system mistakenly attacks the moisture-producing glands, most significantly the salivary and lacrimal (TARE) glands. The result is profound, persistent dryness in the mouth and eyes. Sjogren's affects an estimated 4 million Americans and is dramatically underdiagnosed, with an average diagnostic delay of nearly 3 years from symptom onset. It is notably more common in women over 40 and in adults with other autoimmune conditions such as rheumatoid arthritis or lupus. If your dry mouth is paired with persistently dry, irritated eyes, the feeling that something is always in your eye or that your eyes burn by midday, Sjogren's syndrome deserves consideration. A rheumatologist can evaluate you with a combination of blood tests and clinical examination. Robert sat in Dr. Mercer's office after his test results came back, holding a printed copy of his numbers. "I thought it was just getting older," he said. She shook her head. "Your body has been telling you this for years," she told him. "You just didn't know how to hear it yet." What happens to your body when dry mouth goes unaddressed, and why the mouth is the window to everything? Most people, when they think about dry mouth, think about discomfort. They think about the inconvenience of needing water nearby, the awkwardness of a sticky tongue, the mild embarrassment of bad breath. These are real and they matter. But they are not the most important consequences of ignoring chronic dry mouth. The most important consequences are the ones happening silently, below the surface, in systems of the body that most people don't associate with the inside of their mouth. Because the mouth, in ways that medicine is only recently beginning to fully map, is connected to the rest of the body far more intimately than most people understand. Your mouth and your heart, a connection that should be front-page news. In the early 1990s, epidemiologists began noticing something puzzling. People with severe gum disease had disproportionately high rates of heart disease. At first, this was assumed to be correlation without causation. Perhaps the same lifestyle factors that led to poor dental hygiene also led to poor cardiovascular health. But as the research deepened over the following 3 decades, a more direct mechanism emerged. The bacteria that thrive in the oral environment when saliva is insufficient, particularly a species called Streptococcus mutans and a group of bacteria associated with periodontal gum disease, can enter the bloodstream through inflamed or damaged gum tissue. Once in circulation, these bacteria trigger an inflammatory response in the walls of the arteries. This arterial inflammation is now recognized as a primary driver of atherosclerosis, the buildup of plaque in artery walls that leads to heart attack and stroke. A landmark study published in the Journal of the American Heart Association found that individuals with severe periodontal disease had a 49% higher risk of heart attack and a 28% higher risk of stroke compared to those with healthy gums. These numbers are comparable to the cardiovascular risk posed by high blood pressure and high LDL cholesterol, 2 conditions that receive enormous clinical attention and resources. Chronic dry mouth dramatically increases the risk of periodontal disease. Without sufficient saliva to neutralize acids, wash away food particles, and control bacterial populations, the gum environment deteriorates. Bacteria proliferate, gum tissue inflames, and the chain of consequences that ends in the heart begins in the mouth. For adults over 50, who already carry elevated baseline cardiovascular risk, this connection is not academic. It is a practical, immediate reason to take morning dry mouth seriously. Your mouth and your brain, the dementia connection you've never heard of. The evidence linking oral health to cognitive decline is among the most rapidly growing and surprising bodies of research in medicine today. And dry mouth sits at the center of it. In 2023, a major study published in the Journal of Alzheimer's Disease analyzed data from more than 9,000 adults over 50 and found that those with chronic dry mouth had a significantly elevated risk of developing cognitive impairment over a 10-year follow-up period. The association held even after controlling for age, education, cardiovascular risk factors, and medication use. The proposed mechanisms are multiple and interconnected. The oral bacterium Porphyromonas gingivalis, which proliferates in dry, low saliva environments, produces toxic proteins called gingipains that have now been found in the brains of Alzheimer's patients. Research from the University of Louisville identified these bacterial proteins in 96% of the Alzheimer's brain samples they examined. Additionally, the chronic systemic inflammation associated with periodontal disease, driven by the oral cardiovascular connection described above, is itself a risk factor for neuroinflammation and cognitive decline. The brain is exquisitely sensitive to inflammatory signals, and a body carrying persistent oral inflammation is a body with persistent neurological risk. This does not mean that dry mouth causes dementia. The research is still developing, and causality has not been definitively established. But the association is real, consistent, and significant enough that leading dementia researchers now include oral health as a modifiable risk factor, one that receives far less attention than it deserves. Your mouth and your digestive system, where everything begins. Digestion does not begin in the stomach. It begins in the mouth the moment food enters it. Salivary amylase, an enzyme abundant in healthy saliva, begins breaking down carbohydrates before you swallow. Saliva lubricates the food bolus, making swallowing safer and more efficient. And saliva signals the rest of the digestive system to prepare for incoming food, triggering acid and enzyme production downstream. When saliva production is chronically insufficient, this first stage of digestion is compromised. Carbohydrates arrive in the stomach partially unprocessed. The esophagus handles improperly lubricated food, increasing the risk of abrasion, acid reflux, and the condition known as dysphagia, difficulty swallowing, which affects an estimated 15% of older adults and is a significant risk factor for aspiration pneumonia. The downstream consequences include nutrient malabsorption, increased gastrointestinal discomfort, altered gut microbiome composition, and paradoxically, reduced appetite, as the pleasurable aspects of eating become associated with discomfort and difficulty. For older adults already navigating the appetite changes that come with age, this nutritional spiral can be genuinely dangerous. Your mouth and your sleep, the cycle nobody tells you about. Here is a vicious cycle that deserves direct attention. Chronic dry mouth disrupts sleep quality, and poor sleep quality exacerbates dry mouth. Adults who wake frequently due to oral discomfort, reaching for water, repositioning, dealing with the unpleasant physical sensations of a very dry mouth, experience fragmented sleep architecture. They spend less time in the restorative deep sleep stages that govern immune function, hormone regulation, memory consolidation, and tissue repair. Over time, chronic sleep fragmentation has effects on the body remarkably similar to chronic sleep deprivation, even if total hours in bed seem adequate. And poor sleep, in turn, suppresses the parasympathetic nervous system activity that governs salivary gland function during the night. This means that a body that is already sleeping poorly produces even less saliva during sleep, creating the very conditions that will interrupt sleep the following night. This cycle, once established, is self-sustaining. It does not resolve on its own. It requires deliberate intervention, which is exactly what Part 3 is designed to provide. The dental emergency nobody sees coming. There is one more consequence of chronic dry mouth that demands plain, direct language. It destroys teeth. Not gradually, not eventually, not theoretically. It destroys them with a speed and comprehensiveness that shocks many patients and dentists alike. Without sufficient saliva to neutralize acids, buffer the oral pH, remineralize enamel, and wash away the sugars and acids produced by oral bacteria after every meal, tooth decay accelerates dramatically. Adults with chronic xerostomia, routinely develop cavities at a rate 5 to 10 times higher than they experienced earlier in life, and in unusual locations, such as at the gum line and on the roots of teeth, which are exposed as gums recede with age, where enamel is thinner and less protective. This pattern of decay, called root caries, is one of the most rapidly growing dental public health problems among older Americans. It is expensive to treat, often leading to extractions, bridges, implants, or dentures. And the pain and functional impairment associated with it compounds the appetite and nutritional problems already described. The point is not to frighten you. The point is to make viscerally clear that the symptom you dismiss every morning while reaching for your bedside glass is not a minor inconvenience. It is a window into systemic processes with serious compounding consequences, all of which become more manageable, not less, when you understand them and respond. What to do: the complete doctor-endorsed plan for ending morning dry mouth, and the daily habits that will protect your mouth, your heart, and your brain simultaneously. Dr. Mercer gave Robert a 4-part plan. She was specific, practical, and direct. She did not give him a pamphlet with generic advice. She told him exactly what to do, in what order, and why. What follows is the closest written equivalent of that conversation, based on the current clinical consensus from leading oral medicine specialists, endocrinologists, sleep physicians, and geriatric care experts. Step 1, get the right tests, not the wrong ones. The most important first step is not a product, not a habit, and not a dietary change. It is a conversation with your physician that you may have been avoiding or simply not thinking to initiate. Tell your doctor about your dry mouth. Be specific. How often does it occur? How severe is it when you wake up? How long have you noticed it? And what other symptoms accompany it? Mention increased thirst during the day, frequent urination, fatigue that doesn't resolve with sleep, eye dryness, or any changes in your sense of taste. Based on your symptoms and risk factors, the following tests should be considered: a fasting blood glucose test and HbA1c to rule out or identify prediabetes or type 2 diabetes. These are simple, inexpensive blood draws that provide critical information. If you have not had these checked in the past year and you are over 50, request them at your next visit regardless of dry mouth. A complete medication review. Ask your doctor or pharmacist to systematically evaluate every medication you take for its potential contribution to dry mouth. Bring a complete list. Ask specifically whether any can be substituted, adjusted in timing, or replaced with an alternative that has less impact on salivary function. If you have symptoms of sleep apnea, snoring, unrefreshing sleep, morning headaches, daytime fatigue, ask for a referral for a sleep study or an at-home sleep apnea test. If you have persistent dry eyes alongside dry mouth, ask for a referral to a rheumatologist for Sjogren's syndrome evaluation. None of these tests are invasive. All of them are covered by standard insurance for adults over 50. And the information they provide is the foundation on which every other intervention is built. Step 2, rebuild your hydration architecture. Once systemic causes have been ruled out or addressed, and medication adjustments have been made where possible, hydration becomes the most powerful daily intervention available to you. But hydration done correctly is not simply drink more water. It requires a specific structure. Begin every morning with 12 to 16 ounces of water before anything else, before coffee, before breakfast, before standing up. Keep a full glass on your nightstand the night before so that it is ready the moment your eyes open. This immediate rehydration begins reversing the overnight fluid deficit before the day creates additional demands. Drink water consistently throughout the day, not in large gulps at mealtimes, but in steady, regular sips. A practical method is to keep a water bottle in every location where you spend significant time: kitchen counter, living room side table, bedroom nightstand, car cup holder. Visibility and proximity are the two most reliable drivers of consistent hydration behavior. Reduce or eliminate mouth-drying agents, particularly in the evening hours. Alcohol is profoundly dehydrating and specifically suppresses the body's release of antidiuretic hormone, the hormone that signals the kidneys to retain water during sleep. Even 1 to 2 drinks in the evening measurably increases morning dry mouth. Caffeine, particularly after mid-afternoon, has a similar though less severe effect. Eat your water. Cucumber, celery, watermelon, strawberries, citrus fruits, and leafy greens all have water content above 90%. Including these foods regularly contributes meaningfully to daily hydration and provides the added benefit of stimulating saliva production through chewing. Step 3, implement targeted oral care, specifically designed for dry mouth. Standard oral hygiene, brush twice daily, floss once, is not adequate for adults managing chronic dry mouth. The bacterial environment in an undersalivated mouth is significantly more aggressive, and oral care must be correspondingly more proactive. Brush after every meal, not just morning and night. When saliva cannot perform its post-meal cleaning and neutralizing functions, mechanical removal of food debris and bacteria becomes critical. A soft bristled toothbrush and a fluoride toothpaste, specifically one formulated for dry mouth sensitivity, such as those containing calcium phosphate, are appropriate choices. Use a fluoride rinse at bedtime. Overnight is the highest risk period for dental decay in dry mouth patients. No saliva, no eating, no drinking, and hours of bacterial activity. A brief fluoride rinse before sleep significantly reduces overnight acid damage. Consider xylitol-containing products, mints, gums, or mouth rinses. Xylitol is a natural sugar alcohol that cannot be metabolized by the bacteria most responsible for tooth decay. It actively reduces bacterial populations in the mouth and, importantly, stimulates saliva production through the chewing or sucking reflex. Chewing xylitol gum for 5 minutes after meals can meaningfully improve the oral environment in between brushing. Avoid alcohol-based mouthwashes entirely. The majority of widely advertised commercial mouthwashes, including many popular brands, contain significant amounts of alcohol, which further dries oral tissues and is counterproductive in dry mouth patients. Look specifically for alcohol-free formulations.